I'm Karim Fizazi, medical oncologist in Gustave Roussy in France. Darolutamide is a next generation androgen receptor antagonist. It's chemically distinct from enzalutamide and apalutamide, and perhaps due to that, it doesn't penetrate the blood-brain barrier. It also has a very low potential for drug-drug interaction, and phase 1-2 trials support activity. So this is why we did the ARAMIS phase 3 trial, which is a phase 3 trial looking at patients for non-metastatic castration-resistant prostate cancer. So very similar to PROSPER and SPARTAN with enzalutamide and apalutamide. So obviously the trial is positive by its primary endpoint, metastasis-free survival. But the very good news also is that safety is very, very reassuring with darolutamide. We actually just don't see the CNS-related side effects that we saw with other agents. Also, no excess in falls or fractures, no excess in cardiovascular problems. So this is very reassuring. So yes, the question is whether in the future we will be using darolutamide or enzalutamide or apalutamide. Overall, the good news is that these three agents are very active. Now, whether darolutamide will be better used or mostly used because or thanks to its nice safety profile, it could well be, but of course, data will tell. In ARAMIS with darolutamide, MFS, or metastasis-free survival, was a primary endpoint as in PROSPER and SPARTAN, and in the three trials, MFS is met. What we saw in ARAMIS on top of that is that darolutamide is associated with a 29% reduction in the risk of death and also a 35% reduction in the risk of pain progression. So very meaningful clinical endpoints. Having said that, we need to be cautious because this is still an interim analysis. Data are not completely mature. At 3 years, we saw an absolute difference of 10% between darolutamide and placebo with regards to overall survival, which is very promising. But still, we need more mature data to make sure that this is clear. Now, why did we see that in ARAMIS and not necessarily in PROSPER or SPARTAN? It's always difficult to compare a trial to trial. The maturity of a trial is not necessarily exactly the same. The number of patients is not necessarily exactly the same. We had 1,500 men in ARAMIS, so it's rather big. And of course, all this is event-driven, so the more event, the better chance for the curves to separate. So I guess, again, we need to be cautious when comparing trials. I'm glad, of course, that we saw that in ARAMIS, but these drugs are obviously active. We know that. Let's say that this is very promising regarding the efficacy of darolutamide concerning clinically related endpoints. So Latitude was a phase 3 trial looking at abiraterone in men with high-risk M1 castration-sensitive disease. And patients were truly at high risk. They had to have at least 2 poor risk parameters out of multiple bone metastasis, visceral metastasis, or a high Gleason score, okay? So we were expecting for these men to live about 3 years with ADT alone, and this is actually what happened. What we saw here at ASCO GU was that with a longer follow-up, almost 2 years of additional follow-up as compared to what we had when we primarily reported the data, the delta, the benefit in overall survival remains, and it remains almost exactly the same. It's about an 18-month absolute difference in median overall survival, and it's a 34% reduction in the risk of death, so it's big. And this is even though patients in the control arm receive much more active agents as when we first reported the data, abiraterone, enzalutamide, Taxol, etc., 57% of men in the control arm received those agents. So it's big and very comparable to what we saw for STAMPEDE or CHARTED, for example, for the Taxol trials. Now, again, because this was a high-risk population, all the patients with oligometastatic disease, so low volume disease, were rare in Latitude. So I don't think this is an appropriate trial to look at the subgroup of men. We're just comparing 100 men versus 100 men, and of course, you never know what you're going to see. For high volume disease, and of course, Latitude was really enriched in a high volume disease, the difference is really big, which what we expected because the overall trial is made for that. So one issue that we are now facing in men with either castration-sensitive metastatic disease or even in metastatic CRPC is what best endpoint we should use. Overall survival remains gold, of course, and if ever we can show truly that we can postpone death, we will all be happy. But we also know that it's difficult to achieve. We need a strong drug, strong concept to achieve that. And of course, it can be mitigated by either crossover or using the same drug tested initially for ethical reasons sometimes, or by other drugs being used beyond progression. So we're facing an issue, and when I'm saying we, it's the academic world, but also the agencies, the companies, everybody. So we need to discuss regarding those things. One option is to use radiographic progression-free survival as a primary endpoint, and in some trials this is actually being done with some limitations. We should probably also integrate PROs, patient-reported outcomes, as either primary outcomes or primary endpoints or co-primary endpoints, because if we're not able to truly demonstrate we're postponing death, at least we should show that we're increasing quality of life, for example, on top of radiographic progression. So those are important things. PFS2 is emerging also, something potentially important. Also, when you have a strong benefit during the first part of your PFS assessment, your PFS2 will likely be increased as well. So this is under debate, and it has to also to be discussed trial per trial, I believe.